Now, today we are going to cover the topic maintenance and replacement therapy in pediatrics based on Nelson 22nd edition. What are the goals of maintenance fluid in pediatrics? The first most important goal is to prevent the dehydration. Second goal is to prevent any electrolyte disturbance. Third is to prevent ketoacidosis, which will occur in cases of starvation. And fourth is to prevent the protein degradation. Normal teenager can stay NPO for 12 to 18 hours without need for any maintenance fluid. While in case of infants, the maintenance fluid should be started within 8 hours of last feed, because the chances of an infant going into dehydration is much higher. Glucose is a very important component of maintenance fluid. The glucose in the maintenance fluid only provides 20% of the required calories. Now, these calories will prevent the protein degradation and ketoacidosis. But it does not provide the adequate calories, protein, fat, minerals, or vitamins required. So, a child who is only on maintenance fluid will still lose 0.5 to 1% of body weight each day the child is NPO and not eating anything from the mouth, nil per orally. Now, the Nelson does mention that if the child is NPO for few days, you should start TPN, otherwise the child will lose 0.5 to 1% of the weight each day. But it does not give exact cutoff for how many days a child should be NPO to start the TPN. It just mentions if the child is going to stay NPO for few days, we should start the child on TPN, otherwise the child will lose 0.5 to 1% of the weight each day. Now, water is another very important component of the maintenance fluid. We need water to replace the losses. Now, we have two types of losses. One is the measurable losses, and second is the insensible losses. Now, you all will know the measurable losses will include urine and stools, while insensible losses occur from skin and lungs. How do we calculate the maintenance fluid? We use the holiday cigar formula. For first 10 kg it is 100 ml per kg. Now for the next 10 kg we add 15 ml per kg for each kg more than 20 kg, and if the child is more than 20 kg we'll add 20 ml per kg for each kg above 20 kg. Now we give maintenance fluid orders in terms of ml per hour. So this is the easier way to remember. For first 10 kg you just write 4 ml per kg per hour. Now for the next 10 kg add 2 ml per kg per hour. And now if the child is more than 20 kg, we have the baseline of 60 ml per hour, and in that we add 1 ml per kg per hour, how much ever the weight is more than 20 kg. Now we have seen the children who are overweight. In those children, if we use the maintenance fluid via holiday cigar formula, then it leads to overhydration. So in that we uses the lean body weight. We cannot calculate the exact lean body weight, so we use an estimated lean body weight, which can be calculated by using 50th centile body weight for child's height. So according to the child's height, we will take the 50th centile body weight at that height. Now, what is the upper limit for the maintenance fluid in an adult sized adolescent child, if it is there? Now, the upper limit is 2.4 liters per day. We cannot give more than this. So the normal plasma osmolality is between 285 to 295 milliosmol per kg. So whatever fluid we are giving, it should be isotonic with the plasma osmolality. Otherwise what will happen is, if we give a hypotonic fluid, through a peripheral line, it will enter the water will enter the RBCs and can lead to hemolysis, and also there is risk of hyponatremia. So these are the different fluids which are available. We have 0.9% normal saline, ringer lactate. Both of these have osmolality close to the plasma osmolality. So this is what is written. Isotonic fluid is are recommended as standard maintenance fluid. In surgical patients, we prefer NS or RL. Otherwise, we can also use DNS. Daily electrolyte monitoring should be done if the child is receiving more than 50% maintenance fluid. Now there is a concept of replacement fluid. If there are losses, for example GI losses via vomiting and through nasogastric tube or in the form of diarrhea, then volume by volume replacement should be done. Usually we do the replacement 6 hourly. Now replacement fluid which is preferred in case of NG losses or MSS is normal saline plus 10 milliequivalent per liter of KCl added to it. And in cases of diarrhea, as diarrheal stool contains large amount of bicarbonate as well, so in cases of diarrhea we prefer D5 half NS plus 30 milliequivalent of sodium bicarbonate plus 20 milliequivalent of KCl. Now if the child is anuric, then we cannot calculate the maintenance fluid via Holiday-Cigar formula, as the child is not passing, the measurable losses are not there, the urine the child is not passing. So in that cases we only need to replace the insensible losses, which are 25 to 40% of maintenance fluid, which we calculate via Holiday-Cigar formula. So we give 25 to 40% of the maintenance fluid, and the fluid that we prefer in case of an anuric child is D5 half NS. We do not add potassium because the anuric child usually have hyperkalemia, and we replace it urine output ml by ml with D5 half NS. That is it we have for maintenance fluid. Thank you.